Hello, everyone, and welcome back to another episode of Dentistry Unmasked. My name is David Rice. I'm the chief editor here at DentistryIQ, and with me always is.
Hey everybody, Pam Maragliano-Muniz, Chief Editor for Dental Economics Magazine. Okay, so when you go to a conference and you sit there and sometimes you look at your phone, let's be real. There's times when you are like, wow, that's really interesting. There's times when you are like, wow, that's incredible, but I could never do that. But then there's lectures and presenters that stay with you. And so we were at both of us, we were at the LA Dental Symposium in Los Angeles last year. And so that conference is coming up in November. So always an amazing one. You should check it out. But we were there and we both were blown away by one of the speakers. And we have the honor of having Dr. Erik-Jan Muts with us from the Netherlands. And he is going to chat with us about some really amazing things. So buckle up. Eric, welcome.
Wow, what an amazing introduction. I'm I'm a little bit how would you say, I'm a little silent by such an by such an introduction, but thanks a lot, and truly the honor is mine to be at your show, to be at your podcast. I really enjoyed the interests that there were for the resin infiltration, and I think yeah, also for me, and once again, the LA symposium, it's a wonderful atmosphere, and I really enjoyed it to participate there last year. Yeah.
I will tell you, there were so many things about your presentation that literally had my jaw dropped. And those of you who know me know I'm a really critical audience member of both dentists and speakers because I feel like we should hold ourselves to incredible standards. But there were moments where I was looking at Pam going like, I I don't want this to end. It's like what, you ever watch that movie and you're like, you're really disappointed that it's over. That's how I felt because I thought one of the coolest things I think that I took from it was your creative approach and how, we talk about interdisciplinary care, but how you evolve that even within resin infiltration and restorative dentistry to be so ultra conservative and get the most insane
Yeah.
results, and how
Yeah.
you classified lesions. And as Pam said, like you walked everybody through, like, hey, when you see this, this is how you do it. And I not only was blown away by what you did in your dentistry and how you shared it, but I'm like, oh, I can bring this back to my practice, which is
Yeah.
incredibly unusual at a dental course. So, can you share a little bit about things you shared with us and what you're
Yeah,
doing
of
all
course,
day?
of course. Yeah, of course. I mean, for me, it started, I was in contact with infiltration, or at least with the infiltration technique when I was in university. It was actually my first experience. I saw it and I thought, okay, well, nice. But at university, I was busy doing other stuff. I was not so busy about being like the best dentist or the best student or whatever. But then I was there was a patient, one of the first patients actually I treated in the office, and she asked me, "Could you do something to remove the white discoloration on my front teeth?" And then I just started treating her, and it went out okay. Actually, it went. I had a very nice result. So my first experience with the infiltration technique was a very positive result. And then after treating more cases, I experienced also some failures, and I thought, was that even possible? I mean, the first one, it was good. I repeated the same protocol for the second or maybe the third patient, but it was not a great success. So then, okay, there needs to be something else. There needs to be something about the kind of lesion, or there needs to be something about the depth of the lesion. So that's what when I started to look more into also into the literature. And actually, I tried to combine all different experiences of other clinicians and also what was described in the literature. And then actually, I discovered you have different kind of enamel lesions. So of course, the first one, we all know that, and we've seen it's the white spot lesion, the traditional white spot lesion. So that will be the carious white spot lesion. And that one is obviously one of the most easiest lesions to treat because the process starts from the outside. But we also have different kind of white discolorations of the enamel or orange discolorations. And actually, I was not so well, maybe I was well trained, but I did not pay attention during university. Could be. I mean, I don't want to blame my university, but so I was not aware of actually, well, maybe I was aware of the differences between that there was a difference between fluorosis and MIH and traumatic lesions, but I was not aware of the histological difference between those lesions. And well, after reading about it, it made sense. And it also could explain a little bit the failures that I experienced. So looking back at the failures that I made, I started to understand that it was not my protocol because I was doing the same protocol, but it was actually my diagnosis that did not match the protocol because the protocol originally is designed for carious lesions and it's not designed for fluorosis or for MIH lesions. So I think that was the moment that everything clicked somehow together and thought, okay, I need to pay attention to the diagnosis. I mean, that's the first part. I need to know what kind of lesion I'm looking at. And that's also what I explained during my lecture. I gave them give them most of the times I give some tools for you because sometimes it's not so easy. I mean, sometimes it's very difficult to distinguish the difference between a traumatic hypomineralization and an MIH lesion. So I try to give some tools in the lecture on how to distinguish those two and to set them apart from each other so you can actually use the right protocol to treat the lesions. So that's more or less a little bit my journey towards that. And I think it's very important that if you start treating enamel hypomineralizations, that you know what kind of hypomineralization you're actually treating.
Hmm.
So, how do you identify the differentiation between the two clinically? I think that's a
Yeah.
big challenge for a lot of us.
Yes, of course. For me, still up till today, sometimes it is a big challenge. And sometimes I think, okay, well, then I would go for the most difficult one. So if I would not be 100% sure, and sometimes you always have those cases that set you on the wrong foot, and then but then typically choose the most difficult one because then you are prepared.
Hmm.
I mean, it's always better to be over prepared than to be under prepared. But I think one of the most important things to distinguish different hypomineralizations from each other is to look at the how they to look at them as and to see how they look. For example, would it be a very well defined border of the white spot, and would it be a very soft border and probably multiple tooth involved and is a little bit widespread over multiple teeth in a chronological order? And you can say, okay, this is probably a fluorosis case because fluorosis typically spreads over multiple teeth, doesn't have a well demarcated border around the lesion, but it's more a little bit cloudy. So would you maybe something like that? Um, and that will be a big difference compared to a traumatic hypomineralization because a traumatic hypomineralization is specifically not symmetrical, not multiple teeth involved. Most of the time, only one tooth, and it has a well demarcated border around the hypomineralization. And typically, traumatic hypomineralization can also be discolored. Most of the time, if you then look into the differences between an MIH and a traumatic hypomineralization, MIH is more symmetrical and probably multiple teeth are involved, but also the border is well demarcated. And in both cases, it can be that the superficial enamel is a little bit broken down. We call that post-eruptive enamel breakdown. And that means that the superficial enamel is very weak. And once the teeth are erupted, that enamel is broken down pretty quickly. Specifically in the back teeth, because there are the occlusal forces, of course. On the anterior teeth, it's less common because most of the time the lesions are located on the labial surface of the tooth. So there are no occlusal forces, of course, in that area.
I have so many things I want to talk about. So all right. So what we're talking about obviously is resin infiltration with the icon system, basically.
Yeah, yeah.
And I'm a rule follower, and I think a lot of people are semi rule followers, meaning you read the instructions for use and you follow those instructions verbatim.
Yeah.
And you don't necessarily do that. And so, what I thought, there was a few things that I took away from your lecture that I thought was so amazing was patience is a virtue, and sometimes you need to give the tooth more time. So I want you to share that. But also, prior to your lecture, I would talk to patients and I would say, I can guarantee I can get it better. I can't promise I can make it disappear completely because I wasn't confident in, I guess, my diagnosis, but also how this infiltration would, react with the tooth. And I found, and I still find that sometimes I treat the tooth and I'm like, it's much better. Just go away. And I think saliva also plays a role there. But
Mhm.
you, in some cases, will still bring in minimally invasive composite dentistry. So, would you share your protocols for
Mhm.
how much time you give a tooth to do this, and then also when you need to bring in composite sometimes?
Of course, of course. Well, I think one of the things I was when I started working, I always was about the manual. So reading the instructions, just as what you described, I think most of my colleagues they would say, okay, well, don't use the manual, just do it. That's also an approach. But I was a little bit about the manual, and then I thought for the infiltration, I thought for what situations was this product actually designed? And then I thought, oh, this was designed for primary decay, mainly in the posterior teeth. It was not designed to, okay, it was later on, it was promoted to treat aesthetic lesions, but it was not designed that way. So I thought, okay, well, let's assume this protocol that's attached to the product is more specifically towards those primary carious lesions and not for aesthetic cases. Let's think about how the system is actually working. And then I thought about a sponge, which would suck up some water, for example. And if you would do that, then it takes time before the sponge is fully saturated with water. So I thought, okay, maybe I need to extend the infiltration time. So actually, I thought about doing two things in order to have a better aesthetic result. That would be to increase the etching cycles. So normally the system would say, okay, you do 3 times etching, 2 to 3 times etching cycles. Each etching cycle is about 2 minutes, and then it should be enough. And then you can start your infiltration. Well, if you have a deep lesion, for example, an MIH lesion, you can choose, you probably need to etch a little bit more, or you need to do some air abrasion just in order to remove a little bit of the superficial enamel. And if you want to combine air abrasion with acid etching, then I would suggest to do first a little bit of the air abrasion and then the acid etching with the hydrochloric acid. Then you might add up 1 cycle of acid etching or maybe 2 cycles of etching, and you let it depend on how the tooth looks when you apply the ethanol. You can, every time you do the etching cycle, you apply a little bit of the icon dry or ethanol in order to remove the remnants of the acid etching, but also to remove water. And removing water will facilitate the infiltration procedure. But it also gives you a chance of some kind of pre-visualization. Um, and sometimes I combine that with the transillumination. Maybe I can explain it a little later. But that gives you a little bit of an idea on how many etching cycles you should do. Then on the other hand, you can also decide, okay, I don't want to add up more etching cycles. Maybe the result is still not okay, but I've done already 5 etching cycles. I don't want to do more etching because with every etching cycle, I'm removing more and more enamel, and you don't want to remove too much of the enamel. So what you can do next is extending infiltration time. And sometimes it also happens to me. Sometimes I think, okay, after 4 times of etching, I'm fine. beautiful result, I think, with the pre-visualization, and then I start infiltration, and I see after 5 minutes of infiltration, I still see a small white spot. But then be patient. Don't light cure, because when you light cure, you will freeze the monomers and they won't go any further. Think of the sponge in the water. You will freeze the water, and if the water is frozen, it won't go any further into that sponge. So time is your best friend at that moment. I mean, you maybe I've not done enough etching. We can discuss about that, but I would rather extend my infiltration time instead of adding more etching cycles than 5 etching cycles. So in my experience, you sometimes need to extend that infiltration time, and it's very important that you do it the first time, because don't do it the second infiltration cycle, but do it immediately in the first infiltration cycle. Because once you light cure, remember, you freeze the monomers, and then it will be much, much harder for new monomers to pass them by and to reach the hypermineralization in depth. So I would recommend you to wait until you're satisfied with the aesthetic result. All the white areas should be gone. And that means that in my experience, you need to wait sometimes up to 30 minutes. I would not wait longer than 30 minutes, but about 30 minutes, it will be fine. And if you do so, I never really experienced any problems with operatory lights on, but I also recommended during my lecture to put down the operatory lights, because every operatory has different lights. If you have daylight lamps, or you have direct sunlight, or well, anything else, you need to remove that, and you need to make sure that you can do, without any problems, do a 30-minute infiltration and not have a premature curing by the environmental lights hitting on the tooth. So I think that's very important. And remember, only light cure when you're satisfied with the result, when there was no white left. And I think that is really, for me, at the time that I understood that I could lengthen the infiltration time, was a game changer.
I think you've said so much there on technique and process, but I'm going to rewind it to, all you dentists out there who are listening. When Eric started with, sometimes we can read the instructions for use and live by them. Some of us don't ever read anything and we just jump in. And the truth of the matter is for us to read them, but then to really think and understand, why was this product created? What was its intention? And, you all have big, big, awesome dental brains to say, how can I switch gears based on what I know this was intended for, and maybe how I'm going to use it differently? I think that's a huge distinction for us in dentistry, to maybe not be a slave to the instructions for use, but to have some science and process behind when and why we're going to change them.
Yeah, yeah, of course. I mean, I think that's for every product, would also sometimes be for etching times. I mean, sometimes there would be an instruction in the manual, but you say, hey, okay, I know from university it's better to extend the etching times for enamel, for example. So everything, of course, the manual is, there's people really very smart. People thought about how to create the manual and how to create the protocol. But we are also very smart as a dentist. We are also trained. And I think if you know what you're doing, it's okay to to follow a different protocol. And actually, I think in this situation now, the manufacturer is actually also changing their protocol for the aesthetic lesions. Yeah.
I would also like to rewind because you're talking about the instructions for use, and we sort of jumped into the protocol after you've created a proper diagnosis. And it's not lost on me that there's an art here. So you can play with etching times and infiltration times. But if you're considering infiltrating for upwards of 30 minutes, and we're
Mhm.
going to be careful about the whole environment around us, we
Mhm.
have to talk about isolation. And I was not going to let you go without talking about your beautiful rubber dam clamps. So, would you
Yeah.
share about isolation too?
Yeah, of course. I mean, it's very, very important, and I'm very happy that you're touching that subject, because I think doing proper eye filtration treatments should always be done, no matter how difficult, with a rubber dam isolation. And there are a few reasons for it. I think the materials that we are working with are a little bit differently than what we are normally used to. So let's say for a normal composite restoration, we would work with a phosphoric acid. And in the infiltration treatment, we work with a hydrochloric acid. And hydrochloric acid is a little bit different, works a little bit different. And that means that if you let it stay on the soft tissue, you will create ulcerations within about 30 seconds. So if it's in contact for 30 seconds or more, you will severely damage the soft tissue. And in case, for example, in carious lesions, and sometimes those are very closely located to the soft tissue. If you have a bad brusher who's not brushing his teeth properly, you can have those decalcifications pretty close to the soft tissue. Sometimes it's also very difficult in fluorosis cases or so. And I decided after having some problems, because I had those problems, I need to it was not written in the manual. So I experienced those problems by applying too much of the hydrochloric acid on the soft tissue. And then I saw very bad situations, even weeks after, that the soft tissue was still not completely healed. So then I decided, okay, if I want to do this properly, I should protect my patients from the hydrochloric acid. So make sure that you do not spill the hydrochloric acid on the soft tissue. And then there is another part, and that's the infiltrant. The infiltrant mainly consists out of Tec DMA. And for the dental chemists under us, know that Tec DMA is not such a welcome product in dentistry from chemical wise. So we also need to take care of that. We need to take care of ourselves. So if we spill the material on our gloves, it would be good to change your gloves to protect yourself. And it would also be wise to protect your patients. I mean, the material can very well infiltrate enamel, so that's why we use it. We have a nice enamel infiltration, but it can also harm the cells of your body, of your soft tissue, for example. So also there, it's important to create a barrier. And I think isolation is the way, full rubber dam isolation. Do not try to use liquid dam. I mean, in some cases you can add liquid dam to your full rubber dam isolation, but in basics, go with full rubber dam isolation. And I also, for me, it makes work so much more relaxed. I mean, I don't need to be stressed about what my patient is doing with his tongue. I can chat with my assistant. I can look around, and it's easier to make photos because the lips and cheeks are already retracted. Um, in my experience, I mean, I could not, would be one of the worst things for me to happen in dentistry if I could not use rubber dam isolation anymore. I mean, it's such a, again, such a game changer for me. Although rubber dam isolation, specifically in young children, might sometimes be difficult. We in the European Union, we are much used in placing retainers, lingual or palatal wires, retainers. And sometimes it's a little bit of a struggle to get a proper rubber dam placed over those lingual wires. So that's one of the downsides. But once again, I think with a specific clamp, as you said, with the golden clamps, we gold coat some brinker clamps, and specifically those brinker clamps are very well suited for retraction of the soft tissue, but also to position clamps over teeth which do have a lingual retainer, for example. So if I would treat a tooth 1-1, for example, or would say, no, you call it differently, right? Now I'm making a big mistake. Tooth number
No,
1-1 would
numbers
be
8 and 9.
okay, 8 and 9. Okay. So for example, I would do those two central incisors, then and there would be a lingual retainer from canine to canine. I would then isolate both the second premolar on both sides, the first premolar on both sides. Then I would skip the canine. I would skip the lateral, so don't punch any holes in there. and then punch 2 holes in the centrals. Then put a B4, those are the very small brinker clamps, put 2 B4s on those centrals. What you then have is that you don't have any problems with the lingual retainer, because the small B4 clamps will just push the rubber dam over the central incisors, and no matter if there is a lingual retainer, and you will immediately protect the laterals. So you don't need to worry about air abrasion damaging the lateral. You don't need to worry about over etching also the lateral. Of course, you only do that when there is no white spot on the lateral, but it immediately protects also the neighboring teeth. So that's how I would approach a case with a lingual retainer, for example. Yeah.
I had the most beautiful woman come in yesterday in my office, and she, she was coming in for a small composite restoration, but she wanted to talk about veneers. And I'm looking at her, and her teeth are beautiful. Yes, if you want to make her perfect, perfect, fine. Maybe we could consider orthodontics or something like that. But she came in seeking veneers because her two lateral incisors have not only a little white spot on her facial surfaces, but there's brown on the facial surfaces of the teeth. And so I had to talk her off the ledge and say, yeah, you know what? If you were my sister, went through the whole thing, because veneers were just not, in my opinion, the right approach. Would you share your take about brown lesions? Because white are one story, but those brown, slightly pitted lesions are a little bit different.
Yeah, they are. They are. And also recently, a systematic review was published that actually showed the the synergy of using both bleaching and infiltration technique. So they would state that the results when combining bleaching could be home bleaching. For example, here in the European Union, we can only do home bleaching. We are not allowed to use more than 6% hydrogen peroxide. So we do then home bleaching. But the systematic review actually shows that when you start with bleaching first, it's not only from an aesthetic point of view that you have a better result, but also from a chemical point of view, because those discolorations that you were just describing are actually small, how would you say, those are small proteins inside the enamel. And if you remove them with bleaching, of course, the side effect is that the tooth gets whiter, but it also removes the proteins from the enamel. And by removing the proteins from the enamel, you are facilitating proper infiltration. So that means that if you do bleaching before you do the infiltration procedure will be going more smooth, will be easier. So you enhance the infiltration capacity of the enamel. So you have two things that you reach with bleaching. Most of the people, if there are discolorations, they're very happy if you can make the teeth a little wider and remove the discolorations. So we could do, most of the times, if it's brown pitted staining, probably could be fluorosis. And it's important to understand that with fluorosis, the discolorations are always obtained after eruption. Fluorosis most of the times is not discolored upon eruption. So that means that those pigments, those discolorations, they were obtained over time, and then it's also more easy to remove them with bleaching. So then when you do the bleaching, sometimes it happens that when the teeth get a little wider and then they're more closely to the white spot, that people say, okay, well, I'm completely happy now with after bleaching. I don't need the enamel infiltration. Although when you evaluate immediately after bleaching, sometimes the difference can be bigger because teeth dehydrate after bleaching. And then when there is dehydration, white spot becomes more severely visible. So there is a bigger, and they become more whitish. So that's important to understand. But then when you wait a little longer, they can rehydrate, and then there is less of a difference between the enamel and the hypermineralization. And then when you do the infiltration itself, you facilitate the infiltration if you want to. So for me, if a patient is not satisfied with the color of his tooth or his teeth, I would always suggest to do bleaching first. And for us, that would be home bleaching. And it's important to remember that if you do the bleaching, that you have a little bit of a pause before you do the infiltration. It's also for in-office bleaching, both the cases would be better, because if you do the infiltration too quickly, then you have some of the you don't experience all the benefits of the bleaching to enhance the infiltration, but you will actually um, delay the info, or not delay, or obstruct the infiltration a little bit. So my advice would be to wait 2 to 4 weeks. Mostly I say 4 weeks to be on the safe side, because sometimes patients, well, they, if with home bleaching, they will probably say, oh, I can do another few days, and no one knows. So I would normally say, okay, 4 weeks, that's the cutoff. We need to save some time, and then we can start with the restorative procedure.
So earlier we talked about kind of the genesis of this whole process being posterior in decay. Can you touch a little bit on that process and how you're treating posterior teeth?
Yes, of course, of course. For posterior teeth, you see sometimes on the X-rays, you see those small triangular shaped lesions in the enamel. And I think those cases, specifically when they are only in enamel, those cases are very well suited for the infiltration technique, because what you do is that you will try to restore the shape of the yeah, you will try actually to reinforce the enamel to make it more resistant for the acid attacks of the bacteria. And with the infiltration, you can do something like a proximal sealing. So what I would do, I would really like to see what I'm doing. So therefore, I would separate the teeth before I go in with the infiltration technique itself. It's not described in the protocol, but I like to see what I'm doing. I'm working with a microscope, and then I just want to know what the hell is happening there. And I think it's important, because you need to know whether it's rough or whether it's maybe even cavitated. You don't know. Sometimes you make a different estimation on the X-ray than it is in real life. So I just separate the teeth. You can have those small separation elastics. You let them stay for 3 or 5 days, and then you can actually look in between the teeth. I like to roughen it a little bit with a diamond strip. So just a
Hmm.
diamond abrasion strip, just to roughen it a little bit and to make it also free from plaque and so on. Then we do the etching procedure. Most of the times it's 2 etching cycles of 2 minutes. And then we start with the infiltration procedure. If you do the infiltration procedure in the proximal, obviously, if it's not a cavitated lesion, you would not add any composite on top. So then we would always do 2 etching cycles. And it's just to make sure that everything is nicely filled, and everything is as smooth as possible. And another thing that I wanted to point out is that it's very important to know that the infiltrant is designed to stay inside of the enamel. It's never designed to be on top of the enamel. So if you also, it's important in aesthetic cases, but it's also important in proximal cases. So if you apply the material, you let it stay there for 3 or 5 minutes, for example, and then you want to remove all the excess infiltrant that's on top of the tooth. So only let it stay where it's inside of the tooth. There it needs to do its job. It needs to reinforce the demineralized enamel. It doesn't need to reshape the tooth, because it's just not designed for it, and it's not strong enough for it. It will make discoloration. It will make it easy to discolor. Um, and it doesn't do any good there. So make sure that you remove it just with your air syringe, and only then start light curing. Although if there would be a small cavitation or a little bit of rough enamel, for example, sometimes that can happen, then I would recommend to apply a little bit of flowable to make it smooth, because you want to have the proximal area as smooth as possible so you can clean it easily. And if there are any rough areas, it will be more difficult to clean it for the patient. And I think a smooth proximal area is very, very important.
Do you ever couple
Excellent.
this process with remineralization efforts like silver diamine fluoride or curodont repair? Is there any other type thing that you might consider either
Yeah.
in lieu of or in addition to?
Yeah, yeah. There has also been some studies that show that it doesn't stop. So if you do the resin infiltration properly, so remember not having a thick layer of infiltrant on top of the enamel. That's not where it should be. It should be inside of the enamel. That combining it with fluoride treatment, for example, topical application of fluoride, it does not interfere with each other. So it's not that the infiltrant completely blocks everything. You more have to see that there are parts enamel, and then you have a small part of infiltrant, and you have some enamel, some healthy enamel structure, because you let the normal enamel structure, you let it stay. The only thing is that what you do is that you will add the empty spaces, for example, you will put in there some infiltrant, and that will reinforce the original enamel structure, but you won't destroy the enamel structure. So the original enamel structure will still be able to communicate with the exchange of minerals or fluoride ions or whatever you are applying. And it has an extra additional effect to the prevention of caries. So you can add them to your standard protocol. And at first, I thought that would not work, but literature shows it differently. And you can mix those different techniques together. Although I have to say that if you are using remineralization products on the vestibular side of the teeth, um, the aesthetics most of the time, the enamel can be reinforced, but the aesthetics won't improve as much as with the infiltration procedure. And if
Hmm.
you have done a lot of topical fluoride application, for example, on demineralizations on the anterior teeth, on the labial surface, sometimes it becomes more difficult, at least that's my personal experience. Sometimes it becomes more difficult to treat them with the infiltration technique. I'm not sure, 100% sure exactly why, but sometimes I get a lot of patients referred, and some of them, they have been extensively treated with fluoride application. Of course, it remineralized the enamel, but it did not restore the aesthetic properties. So then they want me to do the infiltration treatment, and I'm just personally experiencing a harder time by trying to infiltrate those lesions. And maybe it has something to do with that there are less more acid resistant, for example, or they're more difficult to infiltrate. I'm not sure about the chemical procedure 100%, but that's what I experience in the aesthetic areas. Yeah.
That makes sense. All right. So you have to tell us about your book.
Yeah, yeah. Well, I'm very happy. I
Yeah.
actually, I'm very happy. I'm finally finishing because I thought I would always already finishing it in with Christmas, but now the publisher is printing it. So I thought I would maybe have it here, but I don't have it here yet. But they're printing it, so I'm super excited. In the first week of September, we will be able to ship it everywhere. And in the book, I explain everything from every detail about the bleaching, about the isolation, about how the infiltration procedure actually works, and of course, also about all the different kind of enamel defects and how you can actually distinguish them from each other, and whether a lesion is superficially located or more deeply located. And I also go in detail on how to do the composite bonding on top of the infiltrant, because I think that actually that what you asked about how to combine the composite, and I didn't even touch that topic yet. But it is very important to pay attention to the adhesive bonding to the infiltrant. Again, here you don't want to have a thick layer of infiltrant on top of the enamel. I would see it more as a weak layer, because I had some failures with very weird composite fractures, like the composite coming off right at the area where I put the infiltrant, but I was
Mm.
just using it too thick of a layer of infiltrant. So I'm explaining those failures in my book, and I'm also explaining all different protocols for all different enamel defects with a lot of pictures. So normally when I buy a book, I like to buy dental books, but then somehow I never find the time to fully read them, but I do have time to look at all the pictures. So I put it in a lot of pictures because I think pictures they can speak a lot of words about how the procedure is also done. So about every step of the treatment, I try to make a picture would actually, well, you can read it by itself without reading all the text. You can read it by looking at the pictures. Yeah. And if you were interested, you can buy the book at our platform at karmadentistry.com. There you can find it, and we ship it worldwide. So if you're interested, of course, I would be very happy to send it to you.
Man, I'm not only interested, but Pam, we need to buy a couple copies of the book, not just for ourselves, but for some of our audience and our listeners. That would be a really amazing
That
gift to
will be
give out
great.
to people. Yeah.
Absolutely. Let's do a giveaway. So
Yeah.
yes, I'm going to mark, I wrote it down. I have a pen right here. I wrote it down September 1st. I'm going to be
Awesome.
looking for it.
Awesome.
So
Amazing.
we didn't get into composite bonding on top of it, but you know what? We should leave people wanting more.
Yes.
So go get the book and learn
Yeah.
about it. Or maybe we can get you to come back and join us again.
Yeah, of course. I would be very happy to do so. I mean, it's kind of funny. It's you think at first when you look at the product and when you look at the treatment, you think it's such a tiny topic. There's not much to it. I mean, you infiltrate the tooth. Yeah, what's about that? I mean, it's not so interesting or not so uh, complicated. But when you start doing it, then you actually find out there are a lot of questions and a lot of steps because you have not maybe not done the treatment before, or you run into, well, issues when doing the treatment. And then when I started reading about it, I thought, well, it's not so easy and not so easy as I thought at the beginning. Actually, there is a lot to talk about such a small topic, I would say. And yeah, it's just the tip of the iceberg that we discussed now. And but there is a lot of interesting yeah, things that you find out when you try to really understand the protocol that you're using. And I think that's not only for resin infiltration, but it's for every dental treatment. If you really dive into it, there is a lot to it. And there's a lot to discover then. So I'm very happy to be a dentist, I would say. There's a lot to discover.
We're very happy to
I
have you in dentistry. We need more people who just love what they do so much and commit to it like you do. So, Pam, I don't know, the time just cranks by.
It really does. And yeah, no, I think that what you're saying is like it's just resonating with me
Gold.
100% because it makes what we do interesting. When people go to work and they're not interested in what they do, maybe they're not asking the questions or they're just accepting the outcomes that they don't have to accept. Or you're using, say, a system like this one dimensionally without really understanding the diagnoses or understanding the potential outcomes. Because let me tell you, people, when you look at his book and you look at his photos or follow him on Instagram, you're going to see that the opportunities to treat a tooth via minimal intervention, it's incredible. So, Erik, would you share where people can find you, follow you, etc.?
Yes, of course. I'm very happy to. You can find me on Instagram. It's drs.erikjan. There you can follow me on and most of the things I put on Instagram. And you can also follow our platform. It's our educational platform. You can see it from oh, sorry, the wrong side, decay. It's from the Karma Dentistry, and that's our website. If you go to Karma middle score dentistry.com, you can find us there, and that will be the main parts where we are active. And I would actually say that I would coming to the States again next year in March. I will be speaking at the Spear Summit in I think it's in Orlando this year, and I'm not the dates. I don't have them ready yet, but I think it's in the end of March. Spear Summit in 2025.
Well, that's fantastic.
Fantastic.
We'll
I
be
love it.
looking out for that.
Yeah,
Absolutely.
absolutely.
Thank
Well,
you.
thank you so much for your time and your expertise and sharing your time with us. I know that, with the time difference and everything, it wasn't the easiest to schedule, but you made this so simple and just so meaningful. So thank you.
Yeah, well, thank you for the amazing opportunity to share time together and to talk about dentistry. I mean, I think if we are able to share our knowledge, everything becomes better. And for us, once again, as dentists, there are so many things that you need to discover. Even when you're a young dentist, there are so many things that you need to develop and you need to discover. And I think by sharing it, um, all over the world, we can help not only other dentists, but also, of course, our own development, and by getting better and better and better every day.
I
So
love it.
thank you for the opportunity.
Friends, listen, we know you're going to love this episode. That's easy to say. So share it with your friends. Pam and I are totally jumping on this book in September. So stay tuned. And I guess until next week's episode, I hope you all have a great rest of your week.
Bye.
Cheers.
Bye bye.
Thank you, everyone, for watching or listening to the show this week. And thanks to our guests and sponsors on this episode.
Please check out our social media at Dr. Pamela_Maragliano and at Dental Economics Official.
Or you can check me out at Ignite DDS or at Dr. David Rice.
And go to dentaleconomics.com to receive dental economics. You can choose to receive DE in print or digitally, and you can also get the details of our Principles of Practice Management conference on our website.
If you have topics or guests or anything you'd like to talk about on the show, send us an email to dentistryunmaskpodcast@gmail.com, and we will do our very best to make it happen. Thanks again, and we'll see you next week.